Hello and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Kristen Rosenthal. Today's episode features a discussion of real-world patient cases and how experts who serve on the National Comprehensive Cancer Network's CLL/SLL panel align their clinical practice with the NCCN guidelines for the management of their patients with CLL or SLL. This episode is part of a larger educational program titled Applying NCCN Guidelines for the Treatment of CLL/SLL in Clinical Practice, the right agent for the right patient at the right time. This podcast features Dr. Farrukh Awan, Professor of Internal Medicine and Director of the Lymphoid Malignancies Program at the Harold C. Simmons Comprehensive Cancer Center, the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Jeremy Abramson, Director of the Center for Lymphoma at the Massachusetts General Hospital, and Associate Professor of Medicine at Harvard Medical School in Boston, Massachusetts. And Dr. Shuo Ma, Professor of Medicine at the Division of Hematology Oncology at Northwestern University Feinberg School of Medicine in Chicago, Illinois. They will be discussing their real-world experiences and providing expert perspectives on the prognostic variables when deciding between regimens, the role of MRD in CLL, results from the Phase II CAPTIVATE trial, choosing among the available covalent BTK inhibitors, preferred partners for anti-CD20 antibodies in CLL/SLL, the role of noncovalent BTK inhibitor pirtobrutinib in CLL/SLL, and the use of CAR T-cell therapy. For more information on Dr. Awan, Dr. Abramson, and Dr. Ma, along with a link to the complete program, including associated downloadable slides, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this topic.
I'm Farrukh Awan, and I'm very happy to introduce my fellow presenters today and talk about CLL and how do we take the NCCN guidelines and applying it to the practice of CLL. A lot of us obviously practice in the US, and NCCN guidelines are primarily developed for the US audience, but also for a global audience. So we inherently have a US bias. I have talked to other folks from other parts of the world, and obviously practice patterns are different based on regulatory issues and various scenarios. So we'll try to keep our personal biases to a minimum. But again, we're also not familiar with what every country or every region in the world has access to. So I think that those are also limitations up front of what we feel might be the appropriate treatment in 2024 for CLL. With me today is Dr. Abramson and Dr. Shuo Ma. So now let's talk about real cases. Some of these are cases that we have managed in the real world. And again, like I said before, this is how we are practicing. Is that the right thing or wrong? That's open for debate. A few important things that I wanted to start off with is how do we prognosticate patients in the current era? What are we doing differently now than we were doing, let's say, 10 years ago or 15 or 20 years ago? So we'll start with Jeremy. How are you managing these prognostic markers in the upfront setting and then also in the relapse setting?
I still check a full rally pack at diagnosis for my patients, IGHV mutational status, a FISH panel, a stimulated karyotype. I include in that FISH panel cyclin D1 to make sure they're not an occult mantle cell lymphoma. And we use a next generation sequencing panel to look for P53 mutations, most foremost, but we can see other recurring mutations, SF3B1, Notch1, and others. As far as what's really important, turns out very little of it. These were all really important in the chemoimmunotherapy era. They're far less important today. What's still important is the 17p deletion or P53 mutation. We know those patients do progress earlier after time-limited therapy with venetoclax and obinutuzumab. Their median PFS is still over 50 months, so it's still pretty good. But I do think those patients are very likely to need additional therapy. It'll sway me a little bit towards thinking about a BTK inhibitor up front for a P53 mutated or 17p deleted patient. The IGHV unmutated patient will also progress a bit earlier after time-limited therapy, but by progressing earlier, it's still longer than a 5-year remission, which is still pretty great, and I really think there's benefit to being off therapy and the attendant side effects thereof. So other than a P53 mutation, 70p deletion, it really doesn't factor into my decision-making per se today. So those are the major things I'm looking for, and then I'm having a conversation with the patient about it.
And a couple of things that I would add to this is that obviously IGHV, once you're mutated, you're always mutated. Once you're unmutated, you're always unmutated. FISH does evolve, can evolve, especially post-therapy. So it's ideal that you do it before starting second-line therapy, or at least that's our standard practice. So a couple of those variables that there's a lot of the NGS testing that we do. Does everyone need to do that? Probably not. Can you get away without it? I think Jeremy said it right. It's just the TP53, 17p deletion. Those are the two things that we need to do. And I think we would like to stress one thing, that del 17p on a FISH is different from TP53 mutations on a PCR or an NGS assay. So having access to both pieces of the puzzle rather than just the FISH is helpful, because you are probably missing a few of these patients by just limiting yourself to the FISH. So I think this is a common thing that we see. Another way that I use IGHV is if the patient is unmutated, if I'm seeing them for the first time, I tend to see those patients sooner rather than the mutated patients. I can prolong the follow-up time, maybe 6 months or a year, or the unmutated, I expect them to need treatment a little sooner. So those are just, again, trivias that we've looked at. But let's talk about the most important question. BTK versus BCL2, right? That's the question that everybody asks. So Shu, I just want to ask you, what are you looking at when you're deciding how to pick one versus the other? Let's say the patient says, Doc, you tell me what to do, and I'll do it. So what patient characteristics would sway you towards one versus the other? I know it's a difficult question, but we just want to start a discussion.
So it's always a long discussion with the patient. And in addition to those, of course, now we also have a lot of clinical trials. So when it's time for discussion for treatment options, it's always a long visit. I do spend a lot of time with the patient laying out the data in terms of the efficacy, the progression-free survival, and also the toxicity. And I think when it comes to individual patients, several factors really matters. One is that I'll look at the patient in terms of the patient's baseline comorbidities, where the patient has significant cardiac disease, significant arrhythmia, difficult to control hypertension, if they have any bleeding tendency, or if they're already taking multiple things that might increase their risk of bleeding, such as anticoagulation or antiplatelets. So those might sway my decision maybe a little bit away from BTK inhibitor, but it's case by case. It's not contraindicated to use BTK inhibitor for patients who are taking, for example, baby aspirin, or who are taking a small molecule anticoagulant. However, if a patient recently had a cardiac stent and they're on dual antiplatelet agents, then I'll be more concerned about potential risk of bleeding by adding the BTK inhibitor to that. If the patient has significant kidney dysfunction, for example, I'll be worried about their ability to handle tumor lysis syndrome. And in that case, I might swing away from the venetoclax-based therapy if they have a high tumor burden, for example, if they have a high TLS risk. And concurrent medications, I already alluded to that. If patients are taking certain medications that are increasing their risk of bleeding, or if there are certain medications that might cause drug interactions, stuff like that. So that's another consideration. And then I look at their tumor features. So if this is a patient that has extremely high risk of tumor lysis syndrome, very bulky adenopathy, and very high white cell count, then I'll let the patient know that there's a very high likelihood of tumor lysis syndrome. You likely need to be admitted to the hospital for the initial initiation of the therapy. So that might, swing away from the venetoclax-based therapy, or if the patient is willing to do that, then that's still a possibility. But in most of the patients, I would say, it's really a toss of the coin. So I think there's really no contraindication for either one. And I think either one will be fine, and either one is likely going to give them quite a long time of disease control. There's no strong reason for choosing one way or the other. So I would say the most common factor for choosing therapy is the patient preference. Whether a patient would like an easy start with a BTK inhibitor, but they're okay with the long-term oral medication, or a patient more willing to invest more time up front with the venetoclax-based limited duration therapy and enjoy treatment-free period after that. So patient preference.
So shared decision-making for you. Sometimes just the commute can be substantial. Can you come back, drive an hour twice a week or every week for 2 to 3 times, depending on what the situation is for blood work and for somebody to see you? I think that's also a consideration. I'm sure it's the same for you guys in Chicago and Boston, especially with the weather, you can't even get an Uber. So what do you think is the role for MRD? Do you think that really makes a difference when you're selecting a BCL2 over a BTK? Obviously, the inherent difference is that you can stop this treatment versus continuous therapy. But does MRD make a difference?
Not officially, and it's not something that I think there's a mandate to check. After all, the CLL14 trial stopped therapy in everybody, regardless of whether they're MRD detectable or not. I check it because knowledge is power. What we do know is that the majority of patients go MRD undetectable on venetoclax obinutuzumab. Very few, if any, patients go MRD undetectable on a single-agent BTK inhibitor, and that's why that's a continuous therapy and why venetoclax obinutuzumab induces deeper remissions and can be time-limited therapy. But we know that the small proportion of patients who are MRD detectable at the end of their 1 year of venetoclax obinutuzumab are likelier to progress than those patients who are MRD undetectable.
You can argue that those patients, then you would increase the anxiety level knowing that they're MRD positive at the end of therapy.
That is correct. So I think there are a few options. You cannot check it. You can check it and use it as an anxiety-inducing tool. Or you can check it and say, I don't really know what to do with this information right now. It does suggest you're likely to progress earlier. We can do exactly what the data would tell us to do, which is to stop therapy and observe. Or, and I have this discussion with my patients, say you're tolerating venetoclax like a rock star. You're having 0 side effects. We know that you're at high risk of progression if we stop it, and we could continue it, and we have that discussion. That, of course, negates the benefit of a time-limited therapy. Thankfully, this is not a common event, but I typically have that discussion with a patient, but it's not a frequent one.
Yeah, so the del17p, TP53 mutated, a lot of us would have a bias towards continuing venetoclax despite MRD. So what role does MRD have? I guess that's another debate. That's an ongoing discussion. If you have MRD-based decisions, then sure, I think it becomes more and more relevant. But as it stands right now, it doesn't really sway, I think, any of us. At this point, from major academic centers, we do check it for most of our patients routinely, either by flow or by the clonoSEQ assay. So that's kind of what the NCCN says, essentially just listing the factors. I think even at the NCCN meetings, and we go through revisions every year. So the point of all of this is just to try to summarize things. And again, some people may have access to this, others may not. But we try to make it as simple as possible. So ideally, the FISH should be done, karyotyping should be done, and so on. But at the minimum, IGHV and a TP53 assessment or del17p is what we would recommend. So let's talk about a few cases. So this is a 71-year-old gentleman, classic age for CLL. So he's had a history of CLL for 3 years and now has progressed the disease. He's been in good health, except for high cholesterol. And at the time of diagnosis, scans had revealed bulky lymphadenopathy. And then blood work now is showing thrombocytopenia. White count is modest, 46,000. Hemoglobin is 9. So the guy needs treatment, basically. I don't think there'll be any debate here. IGHV unmutated, TP53 is wild type, and FISH is positive for 11q. So this is a typical person who has bulky lymphadenopathy associated with the 11q deletion. Patient prefers to be on a clinical trial. So that was his preference. And they got enrolled on the CAPTIVATE study. So that's the venetoclax plus ibrutinib study, time-limited BTK plus BCL2. So he gets enrolled on the ibrutinib venetoclax clinical trial. And then he initially tolerated the ramp-ups just fine, had no issues. However, 6 months into it, he developed significant atrial fibrillation. Again, this is a very common scenario. AFib events happen early on. Poorly controlled hypertension and significant bleeding issues. So he had basically all the problems that you see with ibrutinib because he was on blood thinners and so on. So it just snowballs. So he was managed aggressively and still was able to finish out 1 year of combination therapy and achieved an MRD positive complete remission. So that's again another one that he had still some detectable disease at the completion of therapy. Luckily, he did really well, and he was followed with active surveillance after he finished and was in remission for around roughly 3 to 4 years, and then slowly started developing progressive disease. He has big nodes, his spleen is enlarged, again the same issues, thrombocytopenia, anemia, and now he has a TP53 mutation, so he has evolved. So del17p, TP53 mutated, and 11q deletion. So this person is now evolving, needs therapy, second-line therapy, post-BTK, BCL2. Is there a right answer here? Debatable, right? So any one of you guys want to take a crack? Shu, do you want to see what would be your preferred treatment for this person? 4 years of remission, MRD positive after doublet.
No, I agree with you. There's probably not one single answer. There are a few reasonable choices. For example, you could consider retreatment with the time-limited venetoclax plus obinutuzumab. Although this patient after V plus I still had a MRD positive disease. So I think with the retreatment of venetoclax-based therapy and now he also acquired a 17p deletion, TP53 mutation, so the high-risk feature. So it's not very likely he'll have a long remission with this time-limited therapy. So given that new requirement of the TP53 alteration, I'll probably lean towards more with a continuous therapy with a second-generation BTK inhibitor. I think he's still sensitive to covalent BTK inhibitor. There's no reason to choose pirtobrutinib or CAR-T at this point.
Jeremy, do you agree with this?
Yeah, I think that's totally fair. Oh, it was on CAPTIVATE.
Yes.
Fixed duration
Fixed
ibrutinib.
duration.
Yeah, I totally agree. I would probably give this patient zanubrutinib.
Yeah, so BTK and acalabrutinib, zanubrutinib, I think we can argue about those two. But I think we can all agree that chemotherapy is not an option for this person categorically. Venetoclax or obinutuzumab, my personal bias would be that would be secondary in this option because of the 17p deletion. Not wrong, but just maybe not the preferred option. CAPTIVATE was very impressive, had very deep remissions in the vast majority of patients, and those patients all did really well. So we'll move on to another case. This is now a 74-year-old with a long-standing history of hypertension, diabetes. This is interesting. It gets more complicated. Hypertension, diabetes, chronic kidney disease, classic patient that you would see in your practice, diagnosed with CLL 5 years ago, initially managed with watchful waiting, and now has symptomatic lymphadenopathy, bulky lymph nodes, axillary lymph nodes, splenomegaly, and then he now has anemia, thrombocytopenia, FISH is positive for trisomy 12, TP53 is wild type, IGHV is unmutated, del17p. So fairly maybe aggressive disease, 74-year-old with multiple comorbids, cardiovascular and renal, and now needing therapy with 17p deletion, acalabrutinib, zanubrutinib, rituximab, or Van-Oben. What would be your choice? Again, same argument with this one, del17p. I would probably sway us away from BCL2 to a BTK inhibitor just because of the 17p deletion, although it's not wrong to do it, and that's what's reflected on the NCCN. So with hypertension, diabetes, and chronic kidney disease, Jeremy, any bias towards one BTK versus the other, acala versus zana?
I wouldn't say so. Acalabrutinib appeared to have less hypertension compared to ibrutinib, zanubrutinib. They were quite similar. The truth is I actually think they're very similar drugs, so I don't feel strongly about it. There are a lot of reasons why I would shy away from venetoclax-based therapy in this patient, but I think either zanubrutinib or acalabrutinib would be entirely reasonable.
Rituximab, Shuo Ma, is rituximab even a consideration?
Rituximab really doesn't have a strong activity in CLL, and the only time we would use this single agent rituximab is to treat autoimmune hemolytic anemia or autoimmune thrombocytopenia. In the CLL treatment itself, it really doesn't have a role.
Yeah, and despite that, unfortunately, still in this country, around 10 to 15%, maybe more of patients with CLL in this country in 2024 are still getting treatment with single-agent rituximab as frontline therapy and chemoimmunotherapy, most commonly bendamustine rituximab. So we keep talking about it. Essentially, like Jeremy said, it's an evolution. What you had in the front line, why are you stopping it, and then what do you get in the second line? And this is a discussion on an ongoing basis with the patients. Same thing for high risk, same thing for non-high risk, and the NCCN guidelines kind of flows through that whole scenario on paper, and you can follow along with it. And that's where the ibrutinib venetoclax gets put in, because at least in the US, we don't see the future of ibrutinib, frankly, either with or without venetoclax, because most of the toxicities happen early on with ibrutinib. So getting rid of those would be tricky, even if you do a 12-month therapy. Now, you can argue that we can dose reduce and start at a lower dose and all of that. Again, I think we have demonstrated that there are possibly better and less toxic agents, and more on the way. Who knows? So I think it's time to move on and find new options. So that's why it's in the other recommended regimens rather than the preferred ones. And even in the relapse setting, that's what it is. Will the doublet be an important thing in the future? Possibly. What will be the partner? Will it be acalabrutinib? Will it be zanubrutinib, pirtobrutinib? That remains to be seen. And I think that's why we're all so excited about our patients. It's great for our patients. And like I said, it's a discussion with the patient. So right now, in this country at least, ACALA with or without obinutuzumab is also a very promising regimen with a long progression-free survival, not unreasonable to use it, or zanubrutinib versus all three of them in the del17p deleted patients. You would avoid venetoclax. So that's the only slight caveat. Whether IGHV mutation status makes a difference, we'll have to wait and get more data, but that looks like it may be favoring the BTK inhibitors a little bit at this point. All right, this person that you were talking about recently, he was started on zanubrutinib, had really bad issues with hypertension within the first week of starting therapy. So antihypertensives were optimized, new agents were added. In week 8, patient had a 50% dose reduction and did not have any significant benefit. And finally, treatment was stopped after 4 months, so roughly 16 weeks. He did not want to take zanubrutinib anymore. Blood work was pretty decent at that point. A platelet count was almost back to close to normal, 114. Hemoglobin was better. Lymphadenopathy was down. So he had a good response, but he had significant toxicity, primarily hypertension. So this person then says, I'm not going to have anything that causes this anymore. So whatever BTK inhibitor, he declined that. Actually, I'm dealing with a person exactly like that right now. She doesn't want to go on either ACALA or ibrutinib or Zanu. He was followed for 18 months with watchful waiting, and now he's developing symptoms of his disease and anemia, and now he's okay with starting therapy. He's also clear that he doesn't want to use BTK inhibitor. His FISH is positive for trisomy 12, IGHV and mutated del17p, so high-risk patient needing therapy, doesn't want BTK inhibitor. Pretty simple answer for this patient. What would you recommend? I think we would all agree that the guy doesn't want to get BTK inhibitors again, so venetoclax or obinutuzumab would be a perfectly reasonable treatment option for this gentleman. All right, so I think we all agree now that in the modern era, obinutuzumab is the right partner for CLL, for BTK or BCL2 inhibitors, and most of us have moved on from rituximab. Barring some insurance limitations, I think we all prefer to use obinutuzumab. There are some issues with obinutuzumab, thrombocytopenia and so on, so it has to be managed closely, but for the most part, I think it's definitely appears to be a better antibody as compared to rituximab. And retreatment with zanubrutinib would not be optimal because of the significant adverse events that this person had. All right, so this person gets venetoclax or obinutuzumab, had issues with cytopenias, diarrhea, and decided to stop therapy after 12 months. He achieved a complete remission, but then progresses after 24 months. And now he's 78 years old, no BTK inhibitor resistance. His disease continues to be del17p, TP53 was detected. So this guy, after 24 months with venobin, has now progressive disease with del17p. So what would be your recommendation now? So 2 years of remission with venetoclax plus CD20 antibody. A lot of us feel that that's probably inferior. 3 years or more may be a better argument, and also again with 17p deletion may not be the right thing. The guy doesn't want BTK inhibitors, zanubrutinib is out. Pirtobrutinib, possibly if he's agreeable to trying it, possibly because of the hypertension signal, and then CAR T-cell also remains on the table in somebody who's double refractory. So basically are seeing the same things on the NCCN guidelines is essentially the significance of TP53. He makes us lean towards a BTK versus a BCL2 inhibitor. And then this whole thing about resistance mutation, and is that an exact science? And the answer is it's not. It is definitely helpful, mostly for the BTK space, still an evolving thing for the BCL2 inhibitor. And the CAR T-cell therapy is definitely going to take up off, and more patients will get it. How do you prime the patient? How do you get them through it? How do you safely monitor, manufacture, and so on? I think that there are still challenges with CAR T. And then again, it's not a fix-all for all our patients. Resistance mutation to BTK, that would be the time I would switch to pirtobrutinib and then go to CAR T-cell or any other clinical trial. Again, how would our practice differ from this is every single step of the way, a clinical trial is always the right answer. All right, I'm just going to go through these questions and ask our panelists to help me. So the first one is role of resistance mutations to BTK inhibitors, pirto versus ven. Dr. Mark.
Recently, FDA has approved pirtobrutinib for patients who had a prior BTK inhibitor as well as prior venetoclax, so double refractory patients. So we know that covalent BTK inhibitors, including ibrutinib, acalabrutinib, zanubrutinib, They're all considered covalent BTK inhibitors. They have made a huge difference in CLL patients, and most patients actually tolerate well and respond well with years of disease control. However, with time, patients will actually start to develop resistance. Most commonly, BTK mutations occurred in 56% of patients, and less commonly, PLC gamma-2 mutation, 8% of patients, and there are also 16% of patients who has both a BTK mutation and PLC gamma-2 mutation. Among all of those mutations, the BTK C481S mutation is the most common. So why is that mutation so different? If you look at BTK, so the reason why BTK inhibitor works is by binding to the BTK enzyme and therefore blocking the ATP binding and blocking the catalytic activity of BTK so that it cannot really pass on the signaling transmission to the nucleus. And all of the covalent BTK inhibitors binds to BTK through one amino acid, the C481, through a covalent bond, and therefore the binding is irreversible. In contrast to that, pirtobrutinib binds to the BTK not through covalent binding, rather it's binding to a pocket through non-covalent binding, and therefore it's reversible. And this non-covalent binding is not dependent on one amino acid, is in a pocket. So that's a major difference between the non-covalent versus covalent BTK inhibitors. And when the patient is acquiring the mutation in the C481 amino acid, then all of the covalent BTK inhibitors are no longer able to bind to the BTK, and they're no longer able to work. And in those patients, they'll develop disease progression and resistance to the covalent BTK inhibitors. In contrast to that, because pirtobrutinib, the non-covalent BTK inhibitor, binds to a pocket rather than relying on the C481, so it can still bind to the mutant BTK enzyme, in contrast to the covalent BTK inhibitors. So let's look at pirtobrutinib. So besides being a non-covalent reversible BTK inhibitor, it also has some other unique features. One is that it's a highly selective enzyme. On the kinome map, it is highly selective for binding to BTK and very minimal activity against other off-target effects. And that might explain that it is a very good tolerability. And also, it has a long half-life, and therefore, with a standard dose of 200 milligrams once a day, you can actually maintain the serum concentration above the IC90 throughout the day.
So hopefully it's clear that there are certain mutations which make you resistant to covalent and non-covalent BTK inhibitors. Until we know more about them, I think it's safe to say that maybe covalent BTK inhibitors should be used first, followed by the non-covalent. Once we get more information about how this field is evolving, we can make more definitive recommendations. Another question that I think is relevant, and Jeremy, I'll start with you. Are you using or considering lysocell treatment in patients above 75?
Absolutely. There's no upper age limit, and I've treated patients far more than a decade older than 75. So absolutely, none of we don't use, we think about fitness, organ function, performance status.
Yep, I don't think there's an age limit as far as we're concerned at our center for CAR T-cell therapy. And on that vein, Shuo, if you are going to use pirtobrutinib or you go straight to CAR. So if somebody is double refractory, covalent BTK and venetoclax, do you try the non-covalent, or is there a scenario in which you can skip and go straight to CAR?
That's a tough question. If a patient really cannot get CAR, of course, that's an easy answer. But if a patient are able to get both, I would say I would look at their tumor burden. If their tumor burden is relatively low, I might go straight into CAR, especially for a younger patient, because sometimes with CAR, you can have long-lasting remissions. There are some patients who can have remission lasting for over 10 years, and we don't know if there's a potential chance of cure for those patients. But if they have a high tumor burden, then my feeling is that the chance for them to get into that complete response and sustainable response might be a little lower with the CAR, so I would go with the Pirto first.
All right, so I guess it's a patient-by-patient discussion again. 2 more questions. What is the chance of percentage of flare-up when we hold BTK inhibitors? I think this question gets asked often. So why don't you take a stab at that?
Actually, flare is quite uncommon for a patient who's responding nicely to a BTK inhibitor. For a patient who's progressing on a BTK inhibitor, that's a different story. So we hold BTK inhibitors routinely for surgery, 3 days before and after a minor surgical procedure, 7 days before and after a major surgical procedure. Patients responding, there's no problem with holding the drug. If a patient is progressing and then you hold, particularly if they have a resistance mutation or a p53 mutation, you hold it, their disease can accelerate, because it turns out it is holding the disease in check to some degree. I have to say it's a bigger issue problem with mantle cell lymphoma, which can truly explode when you hold the BTK, but it is a phenomenon that happens in CLL as well.
Yeah, and I generally see that early on in the disease course. If it's 2 years or beyond, occasionally patients will still have a flare, but if you have good disease control, you don't see it as much. So one more question, Shuo, I guess this will be our last question. Are you of the opinion that you should do BTK, BCL2, or BTK, BCL2, BTK inhibitor? So are you of that school of thought that you should max out one pathway before you switch to the other pathway?
I think that's highly debatable. There's some evidence, actually, if you're switching to a different class of treatment, then some of the resistant mutation for BTK might actually disappear. You might be able to reset its mutation profile. So I don't have a strong preference either way, but I think for now, based on the FDA approval, it's basically covalent BTK inhibitor, venetoclax, and then the noncovalent BTK inhibitor.
Thank you very much, Dr. Awan, Dr. Abramson, and Dr. Ma. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, applying NCCN guidelines for the treatment of CLL, SLL in clinical practice, the right agent for the right patient at the right time on the Clinical Care Options website, please click on the link in the show notes. And as always, thanks for listening.